I would like to ask Ms. Jane McClements to get to the stage, and she will present the results of the UK CAPBIL study, and that is a study on resectable early-stage peri-hilar cholangiocarcinomas. Thank you.
Thank you. Good afternoon, and thank you to Helen and the AMMF team for inviting me to speak to you today on the outcomes of the UK nationwide CAPBIL study, looking at outcomes of resectable early-stage peri-hilar cholangiocarcinoma in the UK. We hear repeatedly, and have done already today, that peri-hilar cholangiocarcinoma is aggressive. For patients, surgery offers the only option of cure. However, patients frequently present with an advanced stage tumour involving bilateral hilar structures, or tumours may arise on a pre-existing background of liver disease, making surgery unfeasible. As such, just 15 to 20% of candidates for surgical resection. Even with surgery, the outcomes are poor, with high rates of local recurrence and a 5-year survival estimated to be just 20 to 45%. Furthermore, surgery for hilar liver resections is challenging, associating with high rates of margin involvement, and the complication rates are amongst the highest for any other elective abdominal operation, with rates up to 80% reported in the literature. So what then can we do to improve outcomes for patients with this disease? We've already heard that some groups have looked at the role of liver transplant for peri-hilar cholangiocarcinoma. And whilst early results have been poor, the Mayo Clinic group published that in selected cases following a strict neoadjuvant chemoradiation protocol, that liver transplant associated with favourable outcomes. They demonstrated that in patients with selectable early-stage tumours, which they defined as tumours solitary, less than 3 centimetres in size, with no evidence of nodal metastases, that followed a very strict chemoradiation protocol, had a 5-year survival of 82%, compared to those patients who underwent resection, whose 5-year survival was just 21%. And similarly, favourable results were reported by other transplant centres adopting a similar protocol. And this led some to suggest that liver transplant should be considered as a treatment option following the same protocol for patients with resectable peri-hilar cholangiocarcinoma. And this multi-centre study demonstrated that for patients with de novo, solitary, again, early tumours less than 3 centimetres in size with no evidence of nodal metastases following the Mayo neoadjuvant protocol had a 5-year survival of 54%, significantly better than those who underwent resection, whose 5-year survival was just 29%. Notably in these two studies, the outcomes for patients who underwent resection for so-called early-stage tumours seemed quite low. And along with the controversial suggestion that liver transplant should be considered as a treatment option for patients with resectable early-stage peri-hilar cholangiocarcinoma, led us to investigate, well, what are the current outcomes in the UK for patients with early-stage peri-hilar cholangiocarcinoma? And furthermore, we wanted to identify if there are any prognostic factors that associate with outcome in this group. To do this, we conducted the CAPBIL study. Last year, my colleague, Professor Gomez, presented early results from this study at this meeting. This was a retrospective, multi-centre study involving 24 of the UK centres from across all 4 nations in the UK. Retrospective clinical pathological data was collected on patients with resectable intrahepatic, hilar, and gallbladder cancer. And for the purposes of this study, we clearly focused on the patients with hilar cholangiocarcinoma. Data was collected over an 8-year time period from 22 out of the 24 centres, as 2 centres did not perform hilar liver resection. A total of 1,298 patients were entered into a REDCap database, pales in comparison to the data we've just seen from Thailand. Of these, we excluded 328 patients with intrahepatic cholangiocarcinoma and 518 gallbladder cases, leaving 452 cases of resectable peri-hilar cholangiocarcinoma, of which 2 were excluded due to inadequate data. Of the 450 remaining cases, 138 represented the early stage peri-hilar cholangiocarcinoma, solitary tumours less than 3 centimetres in size with no evidence on nodal metastases at histology. Comparing those with early stage and more advanced stage tumours, there was no significant difference in demographics. Patients with early stage tumours have a median age of 67 years, and there's a male preponderance with close to 2/3 of patients being male. The vast majority of patients, as we know, with hilar tumours are symptomatic at presentation, with between 2/3 of patients being jaundiced in the early stage group and up to 3/4 in the more advanced stage group. There's no significant difference in the workup of patients before surgery. Close to half of patients have a staging laparoscopy, and 1/3 of patients have a CT PET. In keeping with the percentage of patients that presented with jaundice, biliary drainage was performed in over 3/4 of patients. For those with early stage tumours, ERCP was the most commonly adopted method, and 14% of patients required both an ERCP and PTC. There's no significant difference in the rates of liver augmentation procedure to hypertrophy the future liver remnant ahead of surgery, with similar rates observed between early stage and advanced stage tumours. And portal vein embolisation alone was the most frequently adopted method, seen in 16%, although in 7% of early stage cases, dual embolisation was seen. Similarly, with regards to surgical approach, there was no significant difference between the groups. The most commonly adopted operation was an extended right hemihepatectomy with radical bile duct excision and Roux-en-Y hepatocogeginostomy. The caudate lobe was also resected in 65% of cases with early stage tumours, and intraoperative frozen section was sent in 60% of cases. Despite the differences in staging of the tumours, there was no significant difference in the rate of vascular resection, with vein resection performed in 28% of cases with early stage tumours. Arterial resection was rarely performed. With respect to pathology, it comes as no surprise that we did see significant differences between the groups. 80% of the early stage tumours were found to be PT1 or T2 stage, compared to just 69% of the more advanced group. There was no significant difference in grading, with the vast majority in both groups well to moderately well differentiated. By definition, there were no evidence of nodal metastases in the early stage group. However, in the advanced stage group, 60% of cases had evidence of lymph node involvement. In keeping with this, similarly, in the advanced cases, 62% had evidence of vascular invasion, falling to just 41% in the early stage group. And interestingly, the rate of involved resection margin was significantly lower in those with early stage tumours, found to be 1/3 of cases, compared to over half in the more advanced group. We also moved on to examine the surgical outcomes with respect to morbidity and mortality. The overall rate of complications was significantly lower for patients with early stage peri-hilar cholangiocarcinoma, observed in 73% of cases compared to 82% in the more advanced group. However, when we looked at the rate of serious postoperative morbidity, defined as a Clavien-Dindo score greater than or equal to 3A, there was no significant difference seen. The rates of clinically significant post-hepatectomy liver failure after surgery were found to be 9% in the early stage group, and the rate of clinically significant post-operative bile leak was found to be the same. And despite differences in the overall complication rate, there was no significant difference in the 90-day mortality rates between the groups, with a 90-day mortality of 10% in the early stage group. Interestingly, just to note, out of the 13 that developed clinically significant post-hepatectomy liver failure, 6, close to half of these patients, died within the 90 days of surgery. We also examined the surgical outcomes over time, comparing morbidity and mortality rates between 2014 and 2019 with those between 2019 and 2022. And whilst we did not observe any significant difference in overall morbidity or serious morbidity, the 90-day mortality rates have improved significantly over time, reducing from 16% to just 7% in the more recent cohort. Looking then at adjuvant chemotherapy use. You can see the rates of adjuvant chemotherapy were the same between those with early stage tumours and those with more advanced stage tumours, with less than half of patients in the cohort receiving adjuvant chemotherapy following surgery. Not unexpectedly, patients who developed a significant post-operative complication had a significantly lower rate of adjuvant chemotherapy following surgery compared to those patients that did not develop a significant post-operative complication, with rates falling to just a third of patients compared to over half. We also examined and compared patients who received adjuvant chemotherapy compared to those that did not receive chemotherapy over the whole HILAR cohort. And in addition to showing that serious post-operative complication, in particular clinically significant post-hepatectomy liver failure associating with less adjuvant chemotherapy use, we found that patients who are younger, less than 60 years of age, those with higher grade poorly differentiated tumours, and those with involved resection margin were more likely to receive adjuvant chemotherapy, suggesting a selective approach to adjuvant chemotherapy in the cohort. Finally, looking then at the survival outcomes. For this analysis, we excluded 48 patients who died within 30 days of surgery, leaving 402 eligible patients for analysis, of which 125 were classified as early stage peri-hilar cholangiocarcinoma. Over a median follow-up of 31 months, 47 patients had evidence of disease recurrence, and 62 patients were alive at the end of follow-up, 50%, compared to just a third in the more advanced group. For patients with early-stage peri-hilar cholangiocarcinoma, the median disease-free survival was found to be 31 months, significantly better than those with more advanced tumours, whose disease-free survival was found to be 19 months. Similarly, the median overall survival was 43 months for early-stage tumours, compared to just 27 months in those with more advanced tumours. Using multivariable analysis, we identified several prognostic factors. With respect to disease-free survival, we found that in early-stage tumours, patients of male gender and those that developed clinically significant post-hepatectomy liver failure had a worse disease-free survival. With respect to overall survival, we found that preoperative biliary drainage, clinically significant post-hepatectomy liver failure, and tumours that had evidence of vascular invasion had a significantly worse overall survival in the early stage group. And whilst margin involvement was not found to be significant on univariable analysis, it is interesting to note that for patients with early stage peri-hilar cholangiocarcinoma who have a margin clear resection, median overall survival was found to be 53 months. So in summary, early-stage peri-hilar cholangiocarcinoma is common amongst the resectable cohort, representing close to a third of cases. And the outcomes for these patients are significantly better than for advanced cases. We have identified a number of prognostic factors, with preoperative biliary drainage, clinically significant post-hepatectomy liver failure, and vascular invasion being independent prognostic factors of overall survival. Post-operative morbidity rates from hilar resection are clearly high, but the mortality rates have improved over time. And whilst we may not be able to change the biology of this disease, efforts should be made to reduce the risks of post-hepatectomy liver failure, as this will clearly impact on patient outcome. So in conclusion, curative intent resection in experienced centralised UK HPB units associates with good clinical and survival outcomes in early stage peri-hilar cholangiocarcinoma. I'd just like to acknowledge funding for this project and our patient representative, Charlotte Rowe, who sadly is no longer with us. And finally, I'd like to thank each of the 24 centres from across all 4 nations who've contributed to this study, and the eminent Professor Gomez, who's been my partner in the CAPBIL project. Thank you.